Thank you. Can everybody see the slides better now? All right. And if you fall asleep, I've got a laser pointer. I can blind you. So, quality of life instruments are really questionnaires that will look at a patient's kind of physical symptoms and how that interacts with their overall health, kind of medical well-being. We'll measure, aspects of psychological, physical symptoms, how they how they're able to interact in their environment, how they're able to interact with their spouse or their friends, how they're able to function at work, and kind of put that in a standardized format. There's two different types of instruments, and we'll talk a little bit about those later, but in general, they all kind of look roughly at the same dimensions. Primarily what's going to influence quality of life in medical conditions are going to be their physical health, their neurobehavioral symptoms, their personal beliefs, which we'll talk a little bit about as far as expectations with surgical outcomes, and then how they are able to function at home and at work and in their relationship with their spouse. The two different types of instruments are generic and disease specific. The generic instruments are nice. They're not really tailored to any particular disease per se, but they'll kind of assess global well-being in a kind of a general fashion. And the nice thing is that you can use that in order to look at any particular disease. So there may not be let's say a disease-specific questionnaire or there used to not be for Huntington's. Well, you can use these types of instruments to at least assess quality of life in that disease state. They also allow for some comparison between diseases, but they're not really sensitive for any particular disease, and they may lack a lot of features that are important in our patient population that we're going to be talking about, which is Parkinson's, and that they may not adequately assess a lot of the non-motor features and only have a few questions on motor symptoms, which we know are important in surgical outcomes as well. They also aren't as sensitive to detect change longitudinally. The disease-specific are tailored to the population that you're looking at, and they give a little bit more of a detailed picture on how a patient deals with their overall health burden. They're a little bit more sensitive to detect longitudinal change over time. So as we know, Parkinson's is a chronic progressive neurological disorder. As the disease progresses, you'll have a combination of motor and non-motor symptoms. The non-motor symptoms can be more problematic in a subset of patients than the motor symptoms and affect their quality of life. We treat them with dopamine replacement therapy, and a subset of patients who are good candidates, we'll end up treating them with surgical treatments, primarily STN or DBS. We know that as the disease progresses, patients who have motor complications are much more likely to have poor quality of life. We know that dyskinesias, and primarily diphasic dyskinesias, are associated with worse quality of life. And then, of course, young patients tend to have worse scores compared to older patients with just having the disease, the stigma of the disease, decreased sexual satisfaction, and more, obviously, depression. But in addition to the motor symptoms, there's also a list of non-motor features that will impact quality of life in Parkinson's. We'll talk more about how these are or are not affected by surgery later in the talk. But you can see the freezing, depression, anxiety. Autonomic symptoms are quite common and are a strong predictor of poor outcome, as is depression and anxiety. A couple of studies have shown that depression actually can outweigh some of the motor effects that we'll get with quality of life outcomes. When you look at the studies that have been done with quality of life and STN-DBS, most of them have used, and I'll go over a few of the disease-specific questionnaires, but Most of them have used disease-specific questionnaires in combination with or using generic questionnaires. But they don't really assess what's important from a DBS standpoint. So they may look at, how happy somebody is with their overall medical well-being from a Parkinson's standpoint, but they don't really assess how happy somebody is with their neurostimulator. Are they happy with the care that they're getting from their provider? Are they happy with, how inconspicuous the device is? Are they, how important do they relate those things? And which will be what we'll look at in the prospective study I'll talk about in a little bit. These are 3 questionnaires that are fairly commonly used: the PDQ-39, PDQ-ALAF, which is what I currently use in my clinic, and then the PDQ-L. These are the dimensions that they'll assess, and they'll, for the most part, assess kind of the same dimensions. There's different number of questions. So the PDQ-39 is 39 questions. The PDQ-ALF is 33 questions, and these are how the dimensions and how they'll be broken up. And so, if you look, they'll assess social function, self-image, sexuality, sleeping problems, overall just kind of global outlook, physical function, which includes ADLs, independence, and then of course urinary dysfunction or function. The question is, how does DBS affect quality of life, and more specifically for this talk, STN-DBS affect quality of life? And then what actually predicts pre-surgical, as far as if you can look at a patient during their on-off and kind of predict what's going to show greater improvement longitudinally in their quality of life measures. And I went about this in 2 separate ways. I initially did a retrospective study for looking at pre-surgical kind of predictors, and then I did a prospective study. And I used different questionnaires on the 2. I chose on the prospective study to use a modular questionnaire that actually had and I'll go more over these questionnaires, but that had a DBS specific component, so we could look at really what a patient feels is important for their outcome as far as DBS and how satisfied they were with each of those components. So in the retrospective, we approached 40 patients. I think we enrolled 38. And what we looked at was their on-off score, so the pre-DBS on-off score, and then when we see them in yearly follow-ups, we'll then do an on-off score, on-off medication on DBS score. And we looked at their UPDRS, primarily UPDRS motor score, and broke it up into the tremor section, rigidity, akinesia, postural instability, and then motor complications, and then used the PDQ-ALF. And then they would self-rate what they were before surgery and then where they were at that time. And so the PDQ-ALF is 33 questions. Lower score means better quality of life. And the questions are broken up into, so again, which I already mentioned, social function, self-image, sexuality, sleep, outlook, physical function, independence, and urinary function. On average, our patients were about mid-40s when they were first diagnosed with Parkinson's. By the time they were implanted, they were around low 60s. And their average follow-up for the retrospective part was about 1.5 years after they were implanted.
Is that a younger cohort than usual? 45 seems early as an average.
Not for what we had done at Baylor. They were younger on average, probably implant-wise, than what I've done other places in the early mid-60s. I don't know what average age you guys are implanting down here. I suspect it's probably not on average 61, 62. These were their off medicine on DBS and then preoperative off scores. Of course, you found that there was improvement in, is what you'd expect, motor score, dyskinesia, tremor scales, rigidity, akinesia, gait. These were the preoperative retrospective where they would go back and try to recall what they felt their symptoms were prior to surgery and then now. And really the only thing that showed improvement on this was they felt that their sleep was improved after surgery. When you looked at preoperative assessment, we found that people who had more severe tremor. That tended to lead with their preoperative PDQ-ALF. They tended to have worsening scores with social. Image was worse, their independence was worse, and their total score was worse. Whereas dyskinesia, they tend to have poor outlook, as they did with gait as well. Both rigidity and tremor affected sleep. And then looking at change between the pre and post, both with quality of life and motor scores, showed pretty much the same thing, kind of what we expected, that there was correlation with tremor in the same subscales, and that akinesia primarily affected social and function. Gait was primarily outlook and ability to function. This just kind of summarizes what I said, and I didn't include some of the ADL scores, but those weren't necessarily predictive of at least on this study. Now, there are several limitations that we had with this. Obviously, the glaring one is recall bias. You're relying on somebody to remember what they were like a year and a half before, and that was a fairly significant issue. Interestingly, people tended to underestimate their disability, and they've looked at patients' reliability with quality of life questionnaires in a retrospective fashion. They tend to underestimate what their disability was pre-surgery, up to 16%. Maybe that's why there wasn't an improvement in total score pre and post. This wasn't, and this nor the next trial was really designed to assess the role of non-motor symptoms in this patient population. And also, the PDQ-ALF didn't assess satisfaction with the neurostimulator itself. We took that data, and knowing that tremors seemed to be an important predictor, we then looked at, I think it was 20 patients where we who had STN-DBS, and I don't have slides for this, and we did a blinded video assessment of the tremor rating score and we took people who were 3 or 4 on their UPDRS tremor score and showed that there was a significant reduction in Parkinsonian tremor with STN-DBS. And then we also did a retrospective study where we took 23 patients who were going to be treated with STN-DBS. They met standard criteria for surgery. We enrolled 23, but we lost 2 by the second follow-up. I think they had moved. We weren't able to, so I wasn't able to include them. The module that I choose to use, the quality of life questionnaire that we chose to use, it's called the Questions of Life Satisfaction. It's a modular quality of life questionnaire. It has some, and I'll go more over what they specifically entails, but it has some generic questions, but also a movement disorder section, so it's not disease specific, it's specific to movement disorders. And then also has a DBS module where you can assess patient satisfaction with their neurostimulator. And then we did the standard depression scale, UPDRS, dyskinesia scale, and then we also added the EQ5D, which is a generic quality of life scale as well. We looked at them within 30 days prior to their implant, and then at 6 and 12 months. And my primary outcome was change in the movement disorder subscale after DBS. This is a little bit of a kind of a busy slide, but this goes over the individual dimensions in each of the modules. So the general life satisfaction, general health satisfaction, then the movement disorder, and then the DBS. The general life satisfaction essentially look at how happy somebody was or how important they rated their friendship, their ability to interact with their spouse, financial security, occupation, how happy were they with their living conditions, whereas the general health looked more at kind of measures that would be directed towards health-related instead of social. Movement disorder looked at fluidity of movements, balance, hand dexterity, speech, swallowing, bladder, sexual function, sleep, cognition, independence, and conspicuous of illness. And then the DBS module looked at how reliable that they thought the device was. Was it inconspicuous? Were they happy with their physician or, nurse practitioner care? Did they have any side effects, and were they happy with the handheld device? And the way that this was set up is there's two different questions. They would rate how important an item was to them, and then how satisfied. So they could, and then it was a weighted score based on how important the item was. So if they felt their sexual function was extremely important to them, but they were fairly satisfied with it, their score would be weighted. If they felt that their home life was not that important at all, but they had a terrible home life, that would usually get a lower score. And then you would combine it and get a total score for each module. So these are very similar patient populations as before. Again, average age, mid-40s of onset, and mid-age in implantation in the early 60s. Majority of our patients had at least some post-high school education. The majority of them were disabled and married. And I included the on-off Hoehn-Yahr score just because this was actually, talked about later, is actually a predictor that we found for positive outcome. So that's their off and on scores. So this is baseline, and then on average about 7 months, and then on average about a year and a half assessments. Of course, we had improvements in motor complications, as you would expect with the dyskinesia scale. The part 1 of the UPDRS, we didn't see a significant change. We did get improvement with ADLs, and part 3, and these are on stimulator, off medication scores that were maintained through follow-up. One thing, and one reason I highlighted this, and I'll talk about this in a second, was there's a little bit of a decline in follow-up. General life satisfaction did not improve, but they rated, and I think probably the reason was is that's actually the higher the score, the better in this scale, and that's actually a fairly high score, and so I tend to think that that's probably why we didn't get improvement in this, is that they were already fairly satisfied with their social life and home life. But we did see improvement in the general health measure, and of course their movement disorder measure. But you'll notice that and this was on about a year later on average, that we started to decline, or started to show a trend back towards baseline, and that's even in the movement disorder questionnaire, there was a trend back towards baseline. Now this decline wasn't statistically significant, but had I extended it out another 2 years, I mean, it may have been. But that's in spite of improved, maintained motor improvement. The neurostimulators, of course, you can't assist pre-op, but post-op, these just indicate they were fairly satisfied. So the subscales that were improved, of course, the general life satisfaction, none of them were. But as far as the general health satisfaction, they had more energy, they were more independent, they had better controllability and fluidity of movement, they had better balance, their dexterity, ADL scores were better, they had less bodily sensations, which is really a pain measure. They slept better. The only thing that worsened was the articulation and their sexual function worsened. Everything else is pretty much static after surgery. When we looked at neurostimulator questions, the way patients rated what's important to them, they rated as the most important things the absence of side effects of the stimulator, the reliability of the stimulator, and actually the practitioner care is more important than inconspicuous, and the handheld, the ability of the patient to actually change the settings themselves were less important to them. We found that the difference in Hoehn-Yahr on-off scores were a good predictor of overall change in the movement disorder subscale, and that, of course, postoperative improvements in the ADL and the geriatric depression scale also predicted positive improvements in the movement disorder scale. And this is just a summary slide, but essentially, we found both tremor and Hoehn-Yahr scales both were predictive of, primarily predictive of outcome postoperatively. And the patients really placed a fairly high importance when they were rating what's important to them on their motor aspects of the disease, at least of the movement disorder module. And we found, moderate improvement in correlation with the geriatric depression scale, Hoehn-Yahr scale. Part of that may be is that these patients may have placed a stronger influence on their balance and postural stability as far as, and maybe that was more important to this group of patients than maybe some of the other motor features, and why that was predictive, and some of the other, on this prospective study, why some of the other measures were not, from a motor standpoint, predictive of outcome. Of course, a main limitation with this was in the EQ5D, which was generic, which I didn't mention, didn't show improvement, and that may have just been lack of sensitivity, or we just weren't powered enough to detect it. One of the problems with this, even though we used a movement disorder specific scale, is, well, it wasn't Parkinson specific. So although it hit most of the salient features of Parkinson's disease, it didn't hit all the non-motor features. So you weren't getting questions on sleep attacks and drooling, and there weren't maybe as many questions on some of the other autonomic symptoms. And we didn't design this to evaluate non-motor symptoms. So one of the questions I had was, we started to notice a trend back down towards baseline at follow-up and quality of life, in spite of having maintained motor scores. Well, why is that? Are we able to maintain benefit for 10 years? Are we still, even though we know we're going to have motor improvement, are we going to maintain quality of life improvement for 8, 9, 10 years, 15 years down the road? And if we're not, is that because of the presence of non-motor symptoms that are becoming, non-motor symptoms and levodopa unresponsive symptoms, which is probably the case as to why we're losing that quality of life. And in order to do a long-term study, as our patient population gets older, they become, have a higher prevalence of developing Parkinson's dementia, they may not be the best historians. So if you're going to do a long-term study and look at more advanced PD patients to really determine what their quality of life is when they're stage 4 and 5, we're going to have to rely on the caregivers. And are the caregivers actually good healthcare proxies for providing information on quality of life questionnaires? This is from the VA GPI STN study. And this is the 3-year data looking at the quality of life measures. And there was no difference between STN and GPI statistically on the quality of life measures. The reason I'm showing this is they also found at between 24 and 36 months that there started to be a decline in certain measures of quality of life. They found a decline, and this is with the PDQ-39, and so a lower score is better on this scale. They found that cognition and communication were declining and actually back to baseline by 36 months. And a trend towards some decline by 36 months in the total score, but it wasn't statistically significant. And again, this is having maintained normal, good outcome with motor function. There's not that many trials looking at long-term data. This is one looking at up to 8 years. And one of the big issues, and I wanted to go back and relook at my patients, but so many of them are lost to follow-up. You're just not going to be able to get any good information. And if you look at this trial for their 8-year data, they had 12 of their initial 41 still available. This is the motor part looking at their outcome. And the way this is a little bit confusing. This is the baseline of everybody. This is the baseline of people who were still there at 8 years, and this is their 8-year data. And you find that from 5 and 8 years, they continue to maintain good, UPDRS-3 motor scores. Tremors were maintained. Bradykinesia improvements were maintained. They're on-off. The motor complications are maintained. But if you look at they again use the PDQ-39. you'll notice that at 8 years, they start to go back towards baseline. So low risk, of course, better. And their p-values are for worsening. And so the only thing that significantly worsened was communication, although you tended to go back towards baseline for the total score. You tended to go back towards baseline for mobility and actually most of the subscales. But they weren't assessing non-motor symptoms as far as the reason why that happened. So the question is, how do non-motor symptoms affect quality of life? And we, as you would expect, know that non-motor symptoms have a direct impact on a Parkinson patient's quality of life. Some patients will perceive that non-motor symptom to be more bothersome to them than their motor symptoms. Like I mentioned earlier, some studies have found that the non-motor symptoms are more important than the motor complications in predicting quality of life, although most of them are the opposite. Most of them show motor complications, at least initially, are more important. And we know that depression, anxiety, autonomic symptoms are a big predictor of quality of life. Poor cognition, development of dementia, language skills are important in predicting poor quality of life. Fatigue and pain. Fatigue can actually affect multiple domains of quality of life, and this is something that we deal with on a daily basis on our patient population. The vast majority of them have some sort of fatigue, either for sleep or medication induced. But it can affect mobility, outlook, it can affect cognition, bodily discomfort, and total score. Another study took the non-motor symptom questionnaire and then looked at it as far as how does it affect the overall PDQ-39, and found that it does affect it to some extent, although they didn't find that it affected it as much as some of the motor symptoms. So you did have a positive correlation, meaning the more non-motor symptoms you had, the higher your score, the worse your quality of life was globally. So how does surgery affect non-motor symptoms in our patient population? KU did a pretty nice study where they looked at, I think, 24 patients pre and post surgery, and looked at I think on average their follow-up was about a year. And they looked at the non-motor symptom questionnaire and again the PDQ-39 for outcome. On average, they found that 27 of the 30 non-motor questions had shown improvement. On average, their patients had, before surgery, 7 positive non-motor symptoms. After surgery, on average, they had 12 pre-op, and at follow-up about a year, they had about 7. And so there was some improvement. They found that in their study that the most common thing improved from a non-motor symptom was the autonomic symptoms, primarily orthostasis. And that may just be from medication reduction since it was STN-DBS. And then they looked at the non-motor symptom questionnaire at each individual PDQ-39 domain and found that it correlated positively with outcomes in mobility, ADL, cognition, bodily discomfort, and then, of course, total score. So, at least in the short term, non-motor symptoms can be positively effective either by STN-DBS, either directly or indirectly through medication reduction. STN also has a positive impact on pain that's kind of independent of improvements that you're going to get with motor symptoms, and that is, pain is an important predictor for quality of life. Patients who tended to have more cognitive dysfunction after surgery obviously have lower quality of life scores, especially with the ADL sections on whatever domain you're looking at. That's pretty consistent that they're going to have worse ADL scores and total scores. And the one that gets us in trouble sometimes are unreal expectations. I'm actually going to be seeing a patient next week, with the Medtronic rep on somebody who had unrealistic expectations. And motor-wise, they're doing great, but no matter how many times you tell these people that they're not going to be cured, sometimes they believe what they're going to believe. And there has actually been studies showing that that can negate their quality of life improvements that they're going to have and their positive motor benefits. I know Erica will spend, 45 minutes to an hour talking to these people, or Dr. Peterson, sorry, and it's every once in a while we'll have somebody that will have that. So if you're going to do a long-term study, or at least looking at more end-stage Parkinson's disease to really determine what affects their quality of life, you're going to have to rely on the caregivers. And this is a study looking at how patients and caregivers will assess their outcomes after surgery with STN-DBS and looking at quality of life scales. Tried to highlight what was important on this slide. Again, this is the PDQ 39, so lower score the better. And again, there's a little bit of a trend back towards baseline, but for the most part, the caregivers consistently rated patients lower quality of life or worse quality of life than the patient did. And this is just a slide looking at total, the PDQ 39 total. This is the baseline and follow-up at 1 year. And this is, I think this was 3 months. So it's 3 months, 1 year, patient and then caregiver. And the caregivers will consistently rate them worse on most of actually the dimensions of the quality of life measure. Mobility, discomfort, communication, cognition was quite a bit worse. Emotional well-being, which kind of makes it difficult to do some of these long-term. One, getting funding to do a 10-year study just for something like this is probably almost impossible. But even if you're going to take an end-stage population and then try to go back and look at factor analysis of what's important with determining quality of life in these patients, it's going to have some difficulty just because of these types of measures if you're having to rely on caregivers. Now, in my clinic, when I have patients come in and fill out their quality of life measure, a lot of times if they're demented, and I have a multidisciplinary Parkinson clinic, so I'll come in and that's part of my clinic as far as the initial assessment. A lot of times we'll have to have the caregivers help them. You got to get data somehow. But I just understand that they're probably rating them a little bit. They perceive the illness of their spouse maybe a little bit differently, or their parent, than the patient actually does. So most studies, in fact all studies, have pretty much shown motor complications improvement with STN-DBS or GPI. There's not much of a difference between the two with quality of life measures. Consistently throughout the studies, doesn't matter what measure that you're using, mobility, ADL, stigma disease, sleep, recreation, emotional well-being, bodily discomfort are consistently improved, whereas social support, communication, and cognition, not as much. Communication and cognition can decline in some studies. We found that tremors and on-off Honyar scores were positive predictors for outcome. Non-motor symptoms are important as the disease progresses and probably do impact long-term, although they at least appear in the short term to be modulated. There's just not any long-term studies to show how those progress in a STN or actually in any surgical patient, and how that would then correlate with quality of life. It would be important to know that, and as far as how we're going to go about treating these people in the future, but that's going to be a difficult study to do with loss of follow-up and just funding. I got down a little bit early, but these are my little dog, Bubbles. She wasn't very happy last night with me being down here, driving my wife nuts. And that's her boss, Daisy, the little Yorkie dressed up in her Christmas costume. And this is the solar eclipse from about 2 weeks ago. I stuck my iPhone up to my binoculars and took a picture, and lunar eclipse from back in April. The lunar eclipse we had in August, it was cloudy, so I didn't get to take any pictures. This is the other Dr. Diamond. She's an internist. And then just some pictures that I've taken at night. So, any questions? Or? Yes.
Thanks, Alan. That's a real good study. And, for years, neurologists didn't pay much attention to non-motor symptoms, and it's an incredibly important thing. And like yourself, I find myself with many patients devoting more time to their non-motor symptoms than their motor symptoms. And I agree that non-motor symptoms have to be one of the major factors that influence a patient's perception of quality of life. And there are two other variables that I think. The one is patient selection for DBS. I think we all know that I'm not saying this happens with Baylor, but I think we all know that there are some centers that will basically put a DBS in anybody, and those people are not going to have, some of those people are not going to have good outcomes. And so I think that's a variable that has to be taken into consideration. You also touched on unrealistic expectations, and I think that's incredibly important. I have a subpopulation of a few patients I follow who have DBS that neither I nor Dr. Peterson had anything to do with their evaluation or implantation, who basically were told, you're going to be like you were when you were 25 years old. And those people are not happy.
Yep.
And there's not anything I can do.
And it doesn't matter how well you've got them programmed and
Yeah.
how functional they are, they're never going to be happy.
So when I evaluate people for DBS, I really put a lot of time and effort into talking to these people about what their expectations realistically can be. But like you say, there always are going to be a few people who just they're going to hear what they want to hear.
When I first moved to Arkansas, I inherited a fairly large patient population that had DBS and had not been implanted at a university, but had been implanted in the community. And that was the issue that I was coming across, is a lot of people didn't have Parkinson's. And they were never a candidate in the first place. They didn't undergo appropriate evaluations, but they would go to a neurosurgeon in wherever and get implanted and not even go through university setting. They never had, most of them didn't, and I actually published this, most of them didn't have neuropsych, in fact, I don't think any of them had neuropsych testing. They didn't have on-off evaluations. It was a real mess. And that's, at least in my perception, that was a big issue, is Medtronic kind of expanded their services out in the community. I think we were probably implanting people, well, I know we were implanting people who should have never been implanted. Right. And then it's up to us, as Parkinson doctors to then try to go back and fix it, and you just can't. They're never going to be happy at that point, and they tend to believe that there's going to be a greater outcome than what there's going to be, and why can't you fix it? Well, you have MSA, you don't have Parkinson's, and they just don't understand. When I have my patients come in, I give them, even to follow up, I've got the non-motor symptom questionnaire in the clinic, and they just fill it out while they're waiting on me, and have a caregiver strain index that I have caregivers fill out. So then, because I'm lucky enough to where I have a social worker in my clinic, and so if I'm detecting some caregiver strain on that score, I will then have them follow up with the social worker, because as these people will progress, I mean, they're getting dementia and hallucinations, and they're freezing and they're falling, and it's a real strain on the primary caregiver. You kind of fall into a little bit of a hole in that unless you've got money and you can afford to buy, somebody to come in and help you at night, unless you were smart enough to do long-term care insurance, you really get stuck as a caregiver with some of these people. It's really difficult for them. And a lot of, like you, a lot of what we do now, at least in my patient population that I have, is kind of an older dementia population, is really addressing the non-motor features and just try to keep the caregivers safe. especially with the dementia and the patient's safe. Like earlier this week, we had a patient who I've known for a long, long time with PD dementia. And she finally was kind of telling me some of the behaviors he was doing with driving, even though he wasn't supposed to be driving. He ran over her in a golf cart. He decided it'd be a good idea to try to use a power tool and had cuts on his arms from using a saw, and somehow got in the car and went to try to buy a handgun. They wouldn't sell it to him because they couldn't understand him talking because he, pretty severe Parkinson. So, I mean, these are kind of sometimes, and that's of course one extreme, but these are what we end up dealing with as these patients progress. It really becomes quite a social issue. So.
I think it'd be real interesting to see how caregiver strain correlates with caregiver perception of quality of life of the patient.
That would be a fairly logistically easy study to do.
Yeah.
I mean, you could easily do, 30 to 50 consecutive patients and do a factor analysis on that.
But that's also why I think having a caregiver fill out a questionnaire as a proxy for the patient can be a little bit difficult because their perception is skewed by the caregiver burden.
Yes.
Thank you. Very interesting presentation. You brought some, brought to mind some important questions, and I think if you're going to do a long-term study, it seems to me also you need to maybe make a distinction between caregivers, because elderly spouse versus middle-aged children for full-time, versus actually people in the nursing home itself.
Mm-hmm.
The caregivers there can actually interact much more with the patient. And then the follow-up question also is, with long-term, you're going to have some equipment failures and maybe reoperation. So how do you build that into the model?
Yeah. I mean, that's where using the modular questionnaire that actually has a DBS specific component, you'd probably capture some of those dissatisfaction with their device. I tend to think that probably, at least it seems like the children tend to overestimate disability maybe more than the spouse does. I don't know if that's never been looked at, but that seems to be my perception of when I interact with the families of kind of, I don't know if that's because they're just seeing them every, quarter or 6 months, and they're noticing that, dad or mom has really declined and is maybe hallucinating more, whereas the spouse is with them on a daily basis and maybe a little bit more used to the kind of gradual decline. That hasn't been, as far as I know, looked at. Yeah. Yes.
Thank you. So we've talked about caregiver as the proxy for the patient's quality of life, but has there been any study looking at actually the caregiver's quality of life? Because that could be a surrogate marker of their
Yeah, they tend to have lower quality of life scores. There's not been very much looking at that. They're mainly looking at more caregiver strain. Actually, that's a big topic that really hasn't been addressed very well at all in movement disorders, especially if you're looking at, which my other interest is Huntington's disease, and there's just real lack of information with that in general. And both those diseases are going to rely on somebody at some point to at least assist them. Yes.
So it's interesting to me that these correlations where you get the motor improvement, but you don't really see the improvement in the health-related quality of life. And one of the things that back where I was before I came here, I had a lot of surveys that I handed out to all the patients. And one of the things we looked at, there's a epilepsy quality of life scale, and then there's also depression scales. And as with Parkinson's disease, epilepsy also has a very high depression comorbidity, and the numbers are actually quite similar. It's about 30–40%. And what's interesting is two things. One is that you can get people's seizures under better control, and it doesn't necessarily impact. It's the same story. You're treating the primary presenting symptom. You can get things under control, but then the health-related quality of life doesn't really improve that much because these not overt symptoms, it's sort of like non-motor symptoms because they're not non-seizure symptoms, don't necessarily get better. So that's a problem that we see across across diseases. But it also brings up this sort of technical point that if you look at the health-related quality of life questions, there are a lot that overlap with the depression questions and the depression screens, and so there's this the fact that their health-related quality of life doesn't improve is in fact that we're asking the same questions about mood that we're not making better.
Yes.
But then on the flip side, continuing your, on the flip side, there is always some patients who are paradoxically different because I say this because yesterday I saw a patient with clinic and epilepsy, had a long visit, quite emotional that she can't drive after the first seizure, and I also do the same. I asked her to fill out a quality of life and epilepsy questionnaire, and she fills out that, well, I'm feeling very bad because I can't drive, etc., etc. And one of the question is, what do you think your overall quality of life is? And she had marked, couldn't have been better. So I think some of these questions, I mean, there is sometimes a lack of internal consistency in these questions and how the patients respond to it, and that kind of lands up in all of this confusion.
And we have to really actually kind of decide, are these important outcome measures too? I mean, is it really something that, I mean, because pretty much most of the surgical trials now are including that, but I guess the question should be, and I guess we're probably going to continue to do that. It's just really the question is, my question is, why are these people not showing long-term improvement, and is that even really clinically relevant? It'd be really nice if it was just a disease with just one aspect. It'd be, I think, a lot more clear. But as with anything in neurology, it's not like that. They've got 14 or 15 things that can be impacting them on a daily basis. So it makes it really hard to be the patient, unfortunately. Yes.
Along the lines of what you were just saying, for Parkinson's is a progressive disease. So has anybody tried to, all the studies you've shown are very nice, but they're basically just comparing pre and post in the same patient.
Yeah.
Is there anything monitoring controls and how their, quality of life and motor symptoms are compared to these?
There was there was a short study. Actually, this one, I pulled it out, but looking at people who are randomized medically and surgically, and at least short term, the surgical outcomes were better with quality of life, but not everybody improved. As far as there, I can't look at this slide. I haven't looked at this slide in a while. Yeah, there were more. This graph right here looks at improved versus not improved, and there was a significant more of best medical management that were not improved. But overall, they found that there was more improvement with the surgical group than the medical group. But theirs was, they found that the more off time you had, if you could increase the off time, I think by about an hour more a day before surgery, so if they were having more off time before surgery, they tended to do better post-op. That was what they found as being a strong predictor post-operatively.
But they didn't have a control group.
Well, they just did best medical management. Yeah, so it wasn't a true, but that's what they used for control. I mean, it would be nice to know, I mean, on the more advanced people, what's really causing their poor outcomes. And really, how is that different? The other question is, how is that different than a young patient? A younger, actually young onset patient who may have a different outlook on what their disease is. I mean, things that are more important to them are not going to be, probably not the same important to, same weighted importance to a 80-year-old patient as a 50-year-old patient, because they're no longer working. They're financially set, good or bad, whereas a 50-year-old patient, as we know, is still trying to work and worrying that they're not going to be able to work much longer, and how are they going to survive the next 40 years. So that would be an interesting thing to look at too.
Questions? Again, thanks very much. So, but after 10:30, you're okay?
Should we say maybe 11?
And then there's movement sort of video rounds at noon, so that'll be fun.
Perfect.
All right, see you in a little bit.
Can you talk about their room or should I show up?
Well, show up and it's probably going to end up being like the resident, residence have, because we've got 12 candidates, we've got 12 resident candidates today, or 11.
Busy day.
Yeah, so it's this constant stream. We're using the library as our home base for the resident candidates.
Okay.
But
So I should ask for a resident room.
no, just when you come up to the main desk, Brian will be sitting there and he'll show you how to turn this.
Okay, I'll see you at 11.
Great, thanks. Perfect. We're good. I'm gonna just turn this off because I don't know. Local control. Lights and screen. Video off.
I get to go home and have a 4-hour, about a 4-hour half day geriatric neurology course I have to give on Monday for the family practice residents. So I get to go home and work on that this weekend. But they're going to get about 3.5 hours of videos, I think.
Let's see how to turn it off. Our video is off. Connect. Let's see, I'm trying to. See how to turn off the projector. But
I don't see like a power button anywhere.
No, I'm just looking to see if there's a way to. Volume. Lights and screen.
So do you guys project this?
Well, so what we're doing right now is we're recording them, and with the idea that we could later have people call in and get CME and that sort of thing.
Yeah, that's what I was. It'd be nice if you could view it live or.
Well, we were going to stream it live, but we asked when we had our last conference. We can start walking back.
Oh, okay.
When we had our last conference, we have a neurology update every year, and we try to get a bunch of neurologists around the state. We do a pretty good job of pulling in.